My name is Kylie Edwards and I am an anaesthetic registrar and a research fellow with the Perioperative Quality Improvement Project, PQIP. PQIP is an ongoing multi-site project aiming to improve outcomes after major surgery in the UK through local quality improvement activity. It aims to do this through near real-time provision of local and national data supported by improvement science resources. This analysis relates to delivery of process measures for patients undergoing colorectal procedures in PQIP between 2016 and 2020. 11,393 patients are included from 116 sites. They are divided into 3 time periods. Between year 1 and year 3, there were significant improvements for 8 of these processes: individualised risk assessment, HbA1c measurement, active warming in theatre, minimally invasive surgical techniques, and post-operative drinking, eating, and overall composite dreaming. The preoperative and post-operative measures where improvement is seen have been key improvement priorities for the PQIP project, and this association may well be causal. In addition to improvement at the overall cohort level, individual site improvement is also seen. For measures that did not improve, there are 2 interesting subgroups. Firstly, the group where baseline compliance is already high, such as the elements of the surgical site infection bundle. Arguably, these are probably poor targets for further improvement work. There is also a subgroup of measures with low baseline compliance, such as surgical drains, carbohydrate loading, and cardiac output monitoring, where there is clinical equipoise with regards to efficacy. This equipoise may explain the high levels of inter-site variation for these measures that are seen on this graph. The vertical red line represents 80% process delivery at a site. Below this level, we know from previous research that clinical processes are unreliable and chaotic, reflecting a lack of standardisation of delivery. The 80% is not a target, but an indicator to sites below this line that their first improvement intervention needs to be developing systems to standardise process delivery. These data show us that for improvement in perioperative processes, these are achievable goals for most processes. Conversely, improvement interventions in processes where the evidence base is not clear have not been effective in promoting change. Successful and sustainable improvement will require an understanding of structural and cultural factors influencing process delivery locally. These data will form the basis of site selection for a qualitative research project aiming to elucidate these factors and inform further PQIP interventions.